Thank you all for your patient listening. After listening so much about the antibiotics, I hope you have patience to spare some time for fungi as well. So I'll be covering the various briefly on the fungal infections in the ICU. So the outline of my presentation would be to cover the various types of fungal infections, peculiar epidemiology as far as our in the Indian context, and to elaborate upon the risk factors predisposed to fungal infections and various diagnostic tests, including the newer ones, and the treatment strategies. Basically, I'll be outlining the approach towards fungal infection in the ICU. So, there are various types of fungal infections. As we know, the important one is the invasive candidiasis, which constitutes around 80%. And the other ones are the invasive aspergillosis and the mucor, but mainly I'm focusing on this invasive candidiasis aspect. It has two components: candidemia, which is nothing but the bloodstream infection with Candida, and the other one is the deep-seated tissue candidiasis. So, this is a paper from New England Journal of Medicine, which depicts the main routes of entry of fungi. We can see there are two routes. One is the GI route, and another one is the intravascular catheter route. Particularly in chemo patient, neutropenic patient, where there is a mucosal breach, that way the fungi enter the bloodstream. The other, what we encounter is post-surgical patient, wherein there is, because of surgical anastomotic leakages, there is a translocation of gut fungi into the peritoneal cavity. That way, through the peritoneal cavity, the fungi enter the bloodstream. The other route is the intravascular catheter route, wherein due to the contaminant hands of the healthcare workers, the fungi reach the lumen, where they colonize it, form a biofilm. From this biofilm, the fungi settle into the systemic circulations. Once they enter the systemic circulation, virtually any part of the body is affected by fungi, right from the bone to the brain to the lung to the eye, liver, kidney, virtually all parts. So this is old, decade-old global data. It says the incidence of Candida is 10 cases per lakh population. Candida is fourth most common bloodstream infection in ICU, and of late, abdominal Candida is gaining importance. Secondary and tertiary peritonitis and pancreatitis, the incidence of Candida is 7%. So why we are worried about this invasive candidiasis? Because the mortality without treatment can go up to 70 to 80%, and even with treatment the mortality is 40%. It's way too high. And there is a shift in the global from albicans, Candida albicans, there is a shift towards non-albicans species, and there is emerging resistance to fungal drugs, particularly the azoles, and there is a evolving new diagnostic tools and strategies. In this study, you see the Candida as per the ranking order after cons, Staphylococcus, and Enterococcus, is fourth in the ranking order. So, as a probable physician, we will approach a fungal infection through this prototype case. This is a 50-year-old female who is non-diabetic and hypertensive of 10 years duration. She presented with ileal perforation. At arrival, she is semi-conscious, her vitals are unstable, she is in respiratory failure, PFHs are less than 200, and the Apache scores are way high, 23, and so she was intubated, CVC was secured, and TPN was started. So as usual, antibiotics piptas were started, vitals got stabilized, PFHs improved, and after stabilization, patient relief was repaired on the 10th day. So, and third day of post-operative, she developed fever, leukocytosis, and blood cultures were sterile. Antibiotics were changed to meropenem. So, usually we encounter this scenario routine in ICU. So, issues to be addressed in this case are: what are the chances of invasive candidiasis in this patient? Can we predict invasive candidiasis in this patient? What are the investigations to be done? Either the culture-based or non-culture-based, and how frequently we have to send them. Do our patient need antifungal, whether it is prophylaxis or preemptive empathy? At the end of the talk, we will answer all these questions. So this is epidemiology. We see that Candida is 10 to 20 times more common in India compared to the Western population. And this, you see here, the two countries are red flag, India and Brazil. Compared to the developed nations, with 10 cases per lakh population based, we have around 540 cases, this staggering high number. So, we have the global data from EPIC studies, but there is a data lake in India. Please go to the study. This is the largest study on fungal infection in ICU conducted by the CHAN Candida Network. group which took around 2.2 lakh ICU cases were enrolled, and it was conducted in 27 centers. For 1400 cases were established cases of Candida. They saw that the incidence of Candida was 7 per thousand, the mortality was as high as 40%. And they saw that in different centers, the incidence was different. The reason for that was there was different group of difference in the patient groups in ICUs and variations in because they reported centers which are catering to the surgical patient, transplant patients, cancer patient on chemotherapy. They reported higher incidences, and difference in clinical suspicion as usual. Different people like an ID specialist or microbiologist or an intensivist, there are different level of suspicions, and difference in sampling and laboratory incompetence was one of the reasons for difference in incidency. I would say rather laboratory incompetence to pick up fungal infections. So the data, this study estimated that the invasive candidiasis, the case load is around 7 lakh in India with a 40% mortality. That means 3 lakh deaths per year. So this is compared to the we get Candida on the 11th day, whereas the US data said that they get on 23 days. So it's a staggering difference of 12 days. So we know that Candida is a surgery post-surgical patient, the incidence is around 30%. The most common are the GI surgery, 50%, followed by general surgery and vascular surgery. So in this study, the 94% were exposed to antibiotics with median duration of 24 days, and the most commonest antibiotic used is meropenem followed by peptides, and this of the exposed patient, majority there are 2 antibiotics, and some of the cases were on 7 antibiotics as well. The prior antibiotic antifungal exposure was 16%. The commonest one is the azoles. The commonest one of the azoles is the fluconazole. So logistic regression predictors at 30-day mortality with the significant odds and P values these are the independent risk factors. Public health hospitals, because of large patient they take, ICU days, renal failure, CVC, TPN, steroids, and use of antibiotics like polymyxin. These are all independent risk factors which can increase the mortality. Here you can see interesting thing is Apache scores. Even in India, though Apache scores, we get invasive candidiasis and mortality is high. Isn't it? So the summary of this Candida epidemiology is we have high incidence. Our younger patients at 50 years are affected. We get infection early. With lower Apache scores, we get the infections. And the disturbing facts are we have azole resistance as high as 12%, and we have very high mortality for ranging to 40-45%. And Western population they catered only to 5 species, whereas we have here 31 species. So this is a Candida species with Candida tropicus is the commonest one, followed by the albicans, then the Pathophysiology, and so on. So Candida species worldwide they see the albicans in US and Europe. Albicans is still commonest, but in Asia and India we have Candida tropicus as the predominant species. So the summary of this epidemiology is Candida tropicus is commonest. In Asian countries, especially India, Candida albicans is just 30%. We cater to 70% of non-albican species, and Candida glabrata has emerged as an important pathogen in the US, and Pathophysiology is more prominent in Southern Europe. So importance of the species detection is Candida Pathophysiology is less virulent, so there is low mortality because of these, and there's cruzi seen in severe immunodeficiency deficiency states. Pathophysiology can thrive in certain clinical settings owing to its adherence to medical devices, particularly the plastics. Pathophysiology is associated with plastics. So dubulinalis is common in HIV infected patients, particularly in the Western population, but we see very less. So Candida is the incidence is 6%. The importance of this is it is a new threat in India. We are because of its multi-resistant nature. It is resistant to azoles, amphotericin. It is only sensitive to cacanopandis and some studies say the posaconazole. Mortality is high because of this bug. Already the fungus has spread very fast. It affects middle-aged male with low Apache scores, and more the interventions, more the chance of getting Candidaris. And most of them are nosocomial transmission because of 90%, 95% of them are clonal isolates. So how to detect this Candida is the API, Whitehead, BD Phoenix, Microsan, Miley. None of them detect this deadly bug. only the DNA sequence can detect it, but it is available in very less places. The commercial, non-commercial, fish, none of them will detect. IT sequence is the best method, but very few labs is performed. Mild is more future stress. So this red bug has already spread globally. It has reached Colombia, US, 3 continents, and issues are getting shared in US, UK because of this deadly bug. So can you predict invasive candidates and recall the patient? Can you predict invasive candidates in a patient? What are the risk factors? These are the risk factors. In candida colonization, diabetes, renal failure, hemodialysis, severe pancreatitis, high Apaches, post-steroid use, CBC, prolonged ICU stay, broad spectrum antibiotics, PPN. These are all the risk factors. So general risk factors are the hematological malignancy, neutropenia, abdominal surgery, solid organ transplant, etc. So where our patient started, our patient has ICU stay of 7 days, CBC is in place, antibody started, PPN started. So can we suspect invasive candidates in our patient? Are there any predictive rules? Yes. These are predictive rules: colonization index, Candida proposed by Pittet, Candida score proposed by Lyon, predictive rules proposed by Ostrowski, and for patient for pancreatic predictive proposed by DuPont. So coming to the colonization index, so it is nothing but isolation of Candida species from multiple sites. The problem is colonization index is there is a study from Sanjay Gandhi that says that 90 to 95% of our ICU patients are colonized with Candida. So there is an overestimate. There is a false positive, false positive rate of fungi, which leads to more burden on the microbiology lab and over treatment of the patient. So this is not that reliable test. So the second one is the Candida score, which has 4 variables. Multifocal Candida species colonization, surgery, TPN has 1 score, sensitivity sepsis 2 points. If the score is more than 2.5 to 3, then it indicates high risk of Candida infection, and that patient require empirical antifungal treatment. The sensitivity of this test is 81%, and specificity is 74%. The problem with Candida score is same. With high colonization, our ICUs are highly colonized. So the other predictive rule proposed by Ostrowski is if a patient is on mechanical ventilation, he is on systemic antibiotics, he is CVC in place, he is on, if one of them is there, TPN, major surgery, pancreatitis, RRT, then it can predict the chance of candidacy. The specificity of this prediction rule is 83%. However, it lacks sensitivity and positivity value is just 10%. That is the drawback. So the predictive rules usefulness is because of low prevalence, it's marked, and specificity of these tests are 80%, positivity will be less. So prediction rules will aid in the assessment of possibility that the patient has an invasive candidiasis. So coming to the diagnostics, we have these diagnostic tests: direct spectroscopy, culture, histopathology, galactose antigen antibody, beta glucan, PCR. So the advantage of direct microscopy is rapid chip, however, is very insensitive. Cultures, these we require multiple specimens. We can identify species level infections, and also we get this susceptibility pattern also, but it has a sensitivity of less than 50%, and they are very slow, take 3 to 4 days. So histopathology requires invasive procedure, galactose antigen antibody. It is sensitive and specific mainly for Candida albicans and the Aspergillosis. It is not sensitive for other Candida species. Beta glucan, very good test, detects early, sensitive, and also in some studies it is used to monitor therapy. Only it is done in a specialized lab, and the problem with it is even slightest of contamination can lead to false positive beta glucan levels, and it is not specific for some Candida species like the Cryptococcus and the mucor. So Candida PCR is the most sensitive and the specific test, but however it lacks standardization. So culture, gold standard, 40 ml of blood has to be taken from center line and peripheral line, and on aerobic and anaerobic bottle, the sensitivity is comparable to PCR, has 70%. Drawback in this test, it takes 3 days, and sometimes it may take 8 days. So the importance of Candida species is important because drug accessibility varies with Candida species. Please keep in mind. So, how can you identify the species? Non-commercial preparations, we take 3 to 4 days. Most laboratories in India perform this. Commercial phenotypes, what we use in our corporate hospitals. PNF, which take 90 minutes, but it is only specific to Candida albicans. ITS sequences is the best method. It takes 1 day, but it is technically challenging and available in very less places. MALDI is more of a futuristic test. So, what is the role of biomarkers? So these are the biomarkers: procalcitonin, beta-glucan, and Candida PCR. Procalcitonin, they say that the studies which say that procalcitonin level below 5 nanogram per ml, lower procalcitonin level correlate with fungal infection, and higher procalcitonin level favors more in favor of gram-negative sepsis. Beta-glucan detection, it is a very important test. It is present. This is present in almost cell wall of most fungi except Cryptococcus and mucor. So it's very specific test, and this activates factor G to activate factor G, which activates the coagulase cascade. Actually, previously it was used for endotoxin assay. So this is an interesting study on beta-glucan. They use this as to discontinue anti-fungal therapy. They discontinued the echinocandins in the study on the fourth day. They saw that none developed Candida until day 30. So the conclusion of the study was early discontinuation of empirical echinocandin therapy in high ICU patient based on consecutive negative beta-glucan levels may be a reasonable strategy. So Candida PCR is more sensitive compared to beta-glucan, is more sensitive, is less expensive, is highly specific, but it lacks standardization. So summary of this diagnostics is we have high burden, early infection, younger population is affected with lower Apache scores. We have wide variety of Candida species. Predictive rules do not help much due to low positive predictive value. Early diagnosis required as luminum model is high. Blood cultures are gold standard, though the low sensitivity and they take long turnaround time. Identification of Candida species is important. Not high procalcitonin may help to suspect. Beta-glucan is a better test, but not available in most centers. PCR is futuristic. Coming to the treatment aspect, we are lucky to have plethora of antifungal drugs. They have over the centuries. The story started in the year 1960 with the advent of amphotericin. Then came the ketoconazole in the 1970s. Then in the 1980s, we have the era of the fluconazole. In 1990, we got glycosamine amphotericin preparation. In 2000, we got the neberazole, that is the isoconazole, vosiconazole, and the oriconazole, and then the neber and fungus, the echinocandins, the gas fungin, and fungin, the mitofungin. So we should know various sites where these fungi act. The antifungals act on the various sites. So we have 5-fluorocytosine is an anti-mitolytic which acts on the DNA. So azoles act on the cytoplasm. Echinocandins act on the cell wall. Pollins act on the cell membrane. So mechanism of action, azoles act on the, they inhibit the CYP450 enzyme, which is responsible for synthesis of ergosterol, which is one of the important component of the cell membrane, and pollins act on the they bind to sterol, and they cause holes and pores in this cell wall, leading to the leakage of the fungal material and causing fungal cell death. Echinocandins, they bind to beta-1,3-glucan synthesis, which is an important component of cell wall, which causes rupture and disruption of the cell wall and leading to fungal cell death. So we should know the intrinsic sensitivity pattern of common Candida species. If you remember this slide, this is an important slide. So Candida albicans and tropicals, which are the predominant fungi we have, these are pan-sensitive. These are sensitive to azoles, echinocandins, and the amphotericin B. The glybrata and cruci they are getting resistance to fluconazole and the itraconazole. However, they are still retaining their sensitivity to uraconazole. So, but the MIC for fluconazole is going up, and Gluramanda and Pathophysiology are resistant to echinocandins. Please remember, Pathophysiology is resistant to echinocandins. Lusitania is resistant to amphi. So fluconazole, it has both oral and IV formulation. It's a good viability. The loading dose is 800 mg, and the maintenance dose is 400 mg. The loading dose has gone up compared to the previous loading dose because of the increasing MIC to the fluconazoles, and we have to decrease dose in pediatrics less than 50 ml per minute. So oriconazole is available in both oral and IV. It's used mainly for Aspergillosis, and it's also used as a step down oral therapy in fluconazole resistant and oroconazole sensitive pathogens like the cruci and the glybrata. So oriconazole loading dose is 400 mg twice daily, day 1, and 200 mg twice daily. Maintenance, no dose reduction is required for renal failure, but we have to reduce in moderate hepatic impairment by 50%. It's not recommended in severe hepatic failure like the child cirrhosis of liver. So intravenous dose is 6 mg per kg to 12 hourly for 2 doses. When maintenance is 3 mg per kg. Is IV voriconazole is complex is cyclodextrin. Cyclodextrin accumulates in renal failure and intravenous formulation is not recommended in GA for less than 50 ml per minute. So the problem with voriconazole is that we have wide polymorphism in gene encoding voriconazole metabolizing enzyme, because of which there are large variations in serum levels. So that's why we have to monitor. The therapeutic drug level monitoring is advisable in most of the cases. And drug-drug interactions are very common in voriconazole. They interact with the anti-TB drugs and the anti-epileptic drugs. So prosaconazole is levodopa. It has wide range of activity. Its spectrum of activity includes candidiasis, Aspergillosis, mucorrhizis, Cryptococcus fusariasis, and so on. Loading dose is 300 mg BD and followed by for 2 doses then 300 mg OD. No hepatic. Remember, prosaconazole has no hepatic adjustment required, and the injection need to be avoided in severe renal impairment. The drawback is it prolongs QT interval and tough concentration monitoring is required for this. Can cause acquired myocardial excess, and iatrogenic Cushing syndrome, and discontinued in hereditary fructose intolerance. Coming to the newer molecules, isoconazole is it has also a broad, it's a newer molecule, it has a broad spectrum of antifungal. The various studies in Lancet, please go through this. It has a wide range of activity on Candida species, and also it covers Aspergillosis and mucor. Loading dose is 200 mg TID for 6 doses, then 200 mg OD. No dosage adjustment is required in renal failure. 50% dosage adjustment is required in severe hepatic impairment. It's shorter. Compared to other drugs, it shortens QT interval and does not require therapeutic drug concentration monitoring. So echinocandins is another drugs available only in parenteral formulation. They are relatively safe. They have broad spectrum of activity. No dosage adjustment is required in renal failure. However, caspofungin dose reduction required in severe hepatic impairment. So echinocandins are the caspofungin, anulofungin, and micafungin. Dosing is caspofungin loading dose of 70 mg for 50 mg OD, anulofungin 200 mg loading dose and 100 mg OD, micafungin 150 mg loading and 100 mg OD. So polyenes, the standard preparation, the non-lipid preparation like the amphotericin B deoxycholate, and the lipid preparation, these are the liposomal amphotericin B and the amphotericin B lipid complex. These two are available for treatment, whereas amphotericin B cholesterol sulfate is out of market. So polyenes, the fungicidal, these have broad spectrum activity which can cover all Candida species. They are active as mucor and aspergillosis. The loading doses, the dosing is 0.7 mg per kg, whereas in case of glandular dose, the dose goes up to 1 mg per kg. The dose of liposomal amphotericin B is 3 to 5 mg per kg body. So amphotericin toxicity, they are nephrotoxic. They can cause anywhere between 50% cases. Avoid any concomitant administration. Other nephrotoxic drugs like the cholesterol and the ammonium glycine. Proper hydration and saline loading is needed when we give these drugs, because they will reduce the tubular toxicity. Electrolytes, potassium and magnesium leak because of these drugs. So these electrolytes have to be monitored and promptly treated. Infusion related to C liposomal positions are less nephrotoxic. So broad strategy of management would be prophylaxis, preemptive, empirical, and targeted. Prophylaxis is nothing but there is a risk factor and there are no clinical signs and symptoms. Preemptive is the one when there is a biomarker for invasiveness is positive and risk factors are there. The patient has not developed any clinical signs and symptoms, and in such scenario we give preemptive treatment. Empirical treatment is the one when the patient has developed clinical signs and symptoms, there is a risk factor and the fungal cultures are elevated. Targeted strategy is patient has clinical signs and symptoms, biomarkers are positive, there is risk factors and also fungal cultures are positive. So when to give prophylaxis? Routine antifungal prophylaxis of all patients is not recommended because of the concern it will increase resistance and there will be shift to non-allergen species and increased cost, toxicity of antifungal drugs. And prophylaxis advice when there is a underlying risk is high, when it is more than 10%, and particularly intra-abdominal infections during intestinal perforations. And prophylaxis in the pancreas is debatable. Ideal prophylaxis candidate are GI leakage, transplantation of the pancreas or small bowel, selected cases patients of liver transplantation, and extreme lobar. In infants. Indications for prophylaxis are high risk patient like neutropenia, bone marrow transplant patient. The dose is fluconazole prophylaxis is 4 mg daily, fluconazole is 2 mg 3 times daily, and echinocandin particularly liver transplant patients. So this is a broad treatment strategy for fungal management of invasive candidiasis. If a patient has invasive candidiasis, it is proven or probable, and the patient is hemodynamically stable, and there is no risk of glabella and prusa, then we can go ahead with fluconazole. If the patient is unstable and there are risk factors for prusa and glabella, then we have to use the high-dose fungals, the echinocandins, liposomal preparations, or the levodopas. So factors responsible for increased mortality is diffuse awareness, because as we all physicians always try to think in terms of bacterial sepsis. So when we underestimate fungi, therefore there is delay diagnosis, and always there is an inappropriate choice. We use azoles more, inappropriate duration of treatment, because some fungi require longer duration of treatment. So, and often you forget about source control. And as like antibacterial stewardship, there is antifungal stewardship. The command is called the microbial stewardship. The same parallel strategy applies here also. We have to hit hard, hit right, hit early, hit wide. So, because every delay in administration or delay in antifungal administration will increases mortality. So this is Kumar studies and Kumar they saw that in Candida septic shock, the median duration of antifungal administration was 36 hours. Compared to the bacterial septic shock, the antibiotic administration was in 6 hours. There is a humongous difference of around 30 hours before starting the antifungals. Because of these reasons, there is a 10-fold increase in mortality due to fungal infections. So there will be non-specific features. The problem with fungal infection is we can have fever, leukocytosis, adenomatous features, abscess, a wide variety of features they present with. And the empirical treatment when to give when there is persistent fever without obvious source, and fever level is not responding to antibiotics, and if there is any biomarker which is positive, and the predictive rules can help to consider antifungal therapy. So factors influencing choice of an agent are the azole, if there is a history of azole exposure, we can't use azoles one more time. Local epidemiology is very important. Severity of the sicker patient require higher antifungal. Comorbidities are important. User involvement, the duration of antifungal treatment is longer. Drug intolerance is another concern. So whenever we see disseminated candidiasis, we have to always see for the fundus. So there is this white exudate called the Candida endophthalmitis, because the importance of endophthalmitis is the echinocandins don't work here, and the duration of treatment is very high, and often they require surgery. And the Candida skin lesions or tear markers are often rarely seen nowadays. So visual candidiasis can spread to liver, spleen. Whenever there is persistent blood culture positivity, then we have to always suspect Candida endocarditis, because and often we need a transfusion report to this. And when patient is seen surgery, we have to with intravenous catheter we need to rule out Candida endocarditis. So recommendation of fluconazole, hemodynamically stable patient with no previous exposure to azole, and no high level history of fluconazole. Echinocandins when they are recommended is hemodynamically unstable patient, and when there is a previous exposure to azole and patients are neutropenic. When the recommendation is neutropenic patient, and possibly there is additional possibility of Aspergillosis of mucus, and the availability of echinocandins is a high cost. So as with antibiotic de-escalation, there is a antifungal de-escalation as well. When to from echinocandin condition to switch to fluconazole when the isolates are susceptible to fluconazole and the patient is clinically stable. If the bugs if sensitive to fluconazole, like the bugs like the prusa and glabella, we have to stop down fluconazole. So commonly when to use combination antifungal therapy in case of invasive Aspergillosis, refractory to AMB like fluconazole and case of combination we have to use. In cryptocriminal meningitis, we have to use AMB with flucitis. The duration of the treatment 2 weeks after the last negative blood culture in patient, that is in patient without visceral involvement. And central line needs to promptly removed in non-neutropenic patient. Candida ophthalmitis AMB flucitis for 4 weeks along with partial hysterectomy. So broad invasive candidiasis, non-neutropenic patient, you have to consider azole the Candida tropicalisis with higher emulsified fluconazole. You have to remove the catheter. The duration of that is 2 weeks from the clearance. However, the duration is easily defined. Use your clinical judgment. So points to consider neutropenic patient are there is wide use of fluconazole, there is rapid dissemination, echinocandins pollens are preferred, device removal is should be just clinical. There are a lot of diagnoses because we can go through them. The Canada in non-neutropenic patient, you have to use fluconazole, and echinocandin in neutropenic patient you have to always go for echinocandins, amphotericin, or echinocandin prompt device removal, catheter removal strategy. So the echinocandin catheter removal is a reasonable strategy. Echinocandins are suggested to be associated with better outcomes.
So echinocandins, because of the evolving data, the wonder drugs, they are suggested to be associated with better outcomes than those azoles, regardless of the type of candidiasis, Apache-2 spores, and Candida species, except for Candida parasilosis. This because it is Candida parasilosis is resistant to echinocandins. So it is hard to justify withholding these agents as a first choice for treatment. However, there is a subgroup of ambulatory stable low-risk patient for whom primary therapy with fluconazole is acceptable. Triazoles may be preferred in the treatment of candidiasis in conditions in which echinocandins are limited by their pharmacokinetics, like patients with meningitis, endophthalmitis, and urinary tract candidiasis. And patients who have been previously exposed to echinocandins for prolonged periods, in such subgroup of patient we can use fluconazole. The primary requirement for the transition to azoles should be the clinical stabilization of the patient rather than identification of the infecting species and its susceptibility to azoles only. As already said, with probable exception of Candida parasilosis infection. Recent phase 4 studies have incorporate step-down strategy to an oral azole as early as 5 days after the start of intravenous treatment with an echinocandin, provided the infecting Candida has been cleared from the bloodstream and the Candida is susceptible to azoles, and the patient condition is clinically stable, and the patient is capable of taking oral therapy. Accumulating evidence points to the importance of early and appropriate antifungal treatment as a major driver of outcomes. So echinocandins appear to be the drug of first choice for most patients, irrespective of the severity of the illness. However, the total cost effectiveness of this approach needs to be studied in resource limited settings like ours. So this development has marked a paradigm shift in favor of echinocandins and the treatment of invasive candidiasis. This is the approach. Treat early with an echinocandin and step down early to triazole. Provided clinical stabilization of the patient is achieved and the Candida species is isolated and depending upon its susceptibility. Coming to the Candida and acute penetritis, fungal infection of the necrotizing penetritis has worse outcomes than those that compared to the bacterial infections. There is a small series from the report from the Western world, 35 patient with penetritis. Possible infection is in 7% of the patients. Coming to the management of persistent candiduria, the recommendations are candiduria. We have to avoid antifungal stable febrile patient and remove catheter if possible. In high-risk patient like the neutropenic and the patient with urological surgery, fluconazole can be used if the species is susceptible. Coming to the CNS candidiasis, consider this inpatient with intraventricular device. The treatment is liposomal amphotericin in the dose of 3 to 5 mg per kg with cytosine 25 mg per kg per dose 4 times daily, followed by after initial response de-escalate cytosine to 400 mg per day, and we have to remove the infected ventricular device. Our next patient, 60-year-old male, background of COPD and heart disease. For the past 5 years, he was in sepsis. Investigation said and antibodies started. He continued to have fever on fifth day. His respiratory insufficiency worsened. So this is the X-ray of that patient, which shows a right lordosom cavity of a fungal ball. So this is very characteristic of pulmonary aspergillosis. This is a reverse halo sign. Male with the COPD in IHD, he has fever, breathlessness. This is the X-ray of that patient, which shows fungal ball with cavity.
Data in favor of invasive Aspergillosis is very little in ICU, high the score count, high the incidence of Aspergillosis, and probably there is a problem with chronic pulmonary Aspergillosis. Because we as physician, whenever a patient on treated with TB comes with repeated symptoms, we often think that there is a reactivation of TB or there is a drug-resistant TB, but 20% of those cases turn out to be pulmonary Aspergillosis. And the risk factors for Aspergillosis are the liver disease, COPD, steroid therapy, of late the deadly COVID pandemic, H1N1, and other fevers, respiratory symptoms, and lung. So this is the halo sign characteristic we see present in this ball, and this is a characteristic halo which is in invasive Aspergillosis. There is in this Aspergillosis involved in the sinus as characteristic accepted high pace. These are the risk factors. Aspergillosis is the common species, and these are the long list of risk factors for invasive Aspergillosis. Please go through this. And aggravating ingredients are the steroids, intubated patients, malnutrition, poorly controlled lysemic status. Aspergillosis hyphae often represent colonization. However, we require lung biopsy to prove its angiographic nature. So, in our case, we use ball cultures were positive. Ball cultures they drew Aspergillosis fumigators. Galactomannan was positive. Note in ball positivity has high predictive value in case of immunosuppressed patient. However, in critical patient, there is sensitivity just 80%. So this is the definition of pulmonary Aspergillosis. Definitive municipal Aspergillosis, positive histopath, positive culture from non-sterile sites, and Aspergillosis colonization is one of the criteria for protective Aspergillosis not met. So this is the definition. There are 4 criteria to be met. Positive Aspergillosis for respiratory tract, fever, this is signs, fever, recurrent fever, pictures, pain, breathlessness, and you need imaging, you need these factors, neutropenia, treatment, and so in our patient, ball came all galactomannan was positive, and so a note on small note of galactomannan is it is present in cell wall component of Aspergillosis species, most of the species of Aspergillosis and albicans, and the cutoff value of galactomannan is 1.5, and this is meta-analysis of 27 studies says the sensitivity of galactomannan is 17% and the specificity is 89%. This study can be used to exclude invasive Aspergillosis rather than identifying it. And important thing is it may detect invasive Aspergillosis 5 to 8 days before clinical or radiological findings occur. So these are the wide false negative, false positives. Use of antibiotics is important. The beta-lactam antibiotics what we use, peptides or amoxicillin, is a high incidence of false positivity. Voracloz is the first line drug for Aspergillosis. Amphotericin is an alternative. Echinocandin inhibitor sensitivity is there. Combination therapy non-responders, and surgical intervention in individual. Just note on mucormycosis is during the COVID pandemic, India is now being called the mucor capital. So they are having large outbreaks. The various risk factors are there. You know that there is a rhino cerebral mucormycosis. We see pulmonary mucosis and the characteristic branching aseptic hypercapsular mucormycosis. So the management is early diagnosis, extensive surgical treatment, reversing the previous risk factor like reduce the use of steroids and prompt diabetic control. Amphotericin is a drug of choice, and posaconazole is an alternate. Well, we started amphotericin, patient improved, galactomannan became negative. This is a broad strategy for mold infections. As the risk factor already been evaluated for mucor, the diabetes, poorly controlled steroids, the industrial options they said the water is in the flow meters, and a lot of things are attributed for mucor, and these are broad strategy for management. We have to identify the recognized risk group. We have to consider diagnosis of invasive mold infection, obtain imaging. The biomarkers will help. Ball galactomannan in the culture, and depending on the results of the abortus, consider tissue diagnosis and start as a definitive or empirical antifungal therapy. Thank you for your patient listening. Sorry for delaying your lunch.